All right, I want to welcome everybody back to the Clinical Core Seminar Series. This is week 6 of the series. It's August 23rd, 2024. And this week we're happy to welcome back Dr. Arig El-Gharbawy. She's an associate professor and metabolist at Duke and with a large focus on glycogen storage disorders. So we're very happy to have her talk about that again with us. Just some housekeeping things before she gets started. Any questions you can put in the chat. We'll try to get to it either in real time or right after the lecture's over, depending on the urgency. The code Sarah just put in the chat, it's YODBOD. I'm not sure why that is, but type that in and send it in for CME credit if you would like. Next week, we have Dr. Nick Amu, who's going to be talking about urea cycle disorders, so stay tuned for that. And then this will be archived as always, on the SIMD website. With that, I will give it over to you, Arig.
Thank you so much. And I'm so glad to be here again and talking with you. And I modified some of the slides to include a few of the newer disorders that we're seeing, as well as, the new therapies and where we are with them. So today I'm going to go over, again, an overview of glycogen metabolism and talk about the very common hepatic glycogen disorders. I will focus mainly on GSD1 with all the details of the treatment and so forth, simply because it's the most common one that you have, especially GSD1A or UC, and then a rapid overview about of the clinical features and management of the others. I will also talk about GSD5 and 7 just because, again, these are muscle phenotypes of GSDs that we see. And then I'm going to talk about new therapies for GSD. And I hope to, talk about just a couple of the rare forms of GSD that are coming in the picture with whole exome sequencing, bringing them in when we're putting some panels or ordering panels and talk a little bit about them. So I just want to talk about glycogen synthesis, which is part of the metabolism, of course. So we know that glycogen synthesis occurs in the liver. It's very important to know that it also occurs in the muscles and that it requires a process which involves basically initially 3 enzymes, which is glycogenin. And I'm saying these because there are now disorders that are associated with these problems, glycogenin associated, as well as glycogen synthase associated disorders. So the glycogenin is important because it is autoglycosylated and it's the primer for the glucan chain. So if you look at the glucan simple chain, it needs to have a UDP in order for the synthesis to occur. And then glycogen synthase starts after that, okay? And it cannot occur. So glycogen synthase cannot start, expanding that chain unless there was an initiation by glycogenin. So that tells you how important that first step is. And glycogen synthase is going to elongate that synthesis chain in the substance in the presence of UDP glucose. And then after that, we have the branching enzyme. And if you recall, branching enzyme is one of the important ones that are associated with glycogen, again, branching of the glycogen tree, if I could call it that way. I'm simplifying it in a manner that you can remember it, because this branching enzyme is the one that is defective in Anderson's disease, which is GSD type 4. So the synthesis is all through glycogenin, glycogen synthase, and then the branching enzyme. And then after that, we go into the glycogenolysis part of the metabolism. And glycogenolysis mainly requires that you're breaking down the glycogen. So there are other enzymes that are associated with that when it comes to the hepatic metabolism, primarily the glycogen phosphorylase, and that is, part of the GSD type 6, actually. And then there's also phosphorokinase, which is type 9, and I'm going to show you a better picture for that. But then there's also the debranching enzyme, which is associated with, GSD type 3. So again, to break down that glycogen in a shape and form that would allow the utilization of glycogen in a rapid manner, you have to have these enzymes that are working to break it down. So genolysis versus genesis are different, and they don't work at the same time. And this is just a figure to show you again that glycogen synthesis and degradation occur at different times based on the status of the fasting. So, for example, in terms when people are eating or after eating, and you have the step where synthesis is going to be regulated, there's also a change in the hormonal control. So you've got metabolism involves the enzymes that are active during that time, as well as the hormones that are active in that time. So in the case of synthesis, you're going to have more insulin and less of glucagon. And then in the case of degradation, when you need that glucose, you're going to have lower insulin and more glucagon. And we know that the action of glucagon is mainly to break down the glycogen through glycogenolysis. And that's why we say in patients with GSD1, we usually don't like giving them glucagon. In other GSDs, it may be helpful, but not as, let's say, as harmful as it would occur in GSD1. Okay, so glucagon definitely contraindicated there. And then just to show you again the synthesis and how it happens, the enzymes that are involved in this side versus in degradation are very important. And the end stage is glucose oxidation, which is basically breaking down the glucose down into pyruvate. And, if everything goes well, that pyruvate, lactate, and so forth are going to be within normal ranges, and energy is going to be sent to the Krebs cycle. So glycogen metabolism is important for, at the end, priming the mitochondria with energy. So when we are in need of energy, glycogen is rapidly being broken down to produce glucose. In the liver, the breakdown of the glycogen occurs when there's fasting, and it's crucial to maintain normal glycemia. And that's important because sugar is the main fuel to the brain. Also, in active muscles, glucose is an immediate essential energy source for exercise, especially during the first 30 minutes. So that's important to know too. And then despite glycogen is mobilized during fasting in both the liver and the muscle lacks the glucose 6-phosphatase complex. So GSD type 1, where the glucose 6-phosphatase complex is abnormal, I'm talking about 1A in this case because complex is in 1A, that enzyme is missing in the muscle. So there's no muscle disease associated with GSD1. And the muscle actually is a very eager organ to take from the systemic circulation, meaning from the liver, glucose when it needs it, especially in exercise. So that adds to one of the reasons why patients with GSD1A, when they're active, their blood sugars may drop. So the sources of blood glucose at the end, we can say that diet is not always reliable and depends upon the amount of food we eat and the type of food we eat, the type of carbohydrate, whether it was a simple sugar versus a complex sugar, lasting a longer time than a simple one, and on the breakdown of glycogen. So glycogenolysis will be leading to a rapid availability of supply of glucose in terms of fasting for a certain amount of time, and then gluconeogenesis sets in after that. So if glycogenolysis, the glycogen from that is depleted, then gluconeogenesis, which is making sugar from other substrates, kicks in. And these are the forms of the utilization of glucose. So initially we get it from exogenous sources in the food, and then glycogenolysis will start protecting the patient, and it all depends on age of the patient, the availability of liver stores in the organs, specifically I'm talking about the liver in this case. And then after a period of time of fasting, which can be variable in individuals, the glycogenolysis will be replaced by gluconeogenesis. And if you look at the gluconeogenesis substrates that can work, you can see lactate, pyruvate, glycerol, and amino acids work as these substrates. And there are stages of starvation. So we know that the early post-absorptive state, we do have some sugars coming from that. And then if there's some fasting for around 10, 12 hours. You can have glycogenolysis up to 18 hours or to 24 in some people. And then you set into, with early starvation, gluconeogenesis. And then after that, ketone body formation, and you need an intact, beta oxidation through the mitochondria for that. So the glycogen storage disorders come from any step in the enzymes that are associated with either the gluconeogenesis process or the glycogenolysis process, where you have a defective enzyme. So in that case, you can see that it either comes from, on the synthesis side, branching enzyme defect or glycogen synthase. Glycogen synthase is GSD0, branching enzyme GSD4, and then you go down the case here. So the phosphorylase kinase is with a GSD9, the X-linked form, and then the liver phosphorylase is GSD6, muscle phosphorylase GSD5, which is McArdle disease. The branching is GSD3, and then you keep on going down here. You can see glucose 6-phosphatase complex GSD1, and then the transporter GSD1B, so 1A, 1B, and then phosphofructokinase, which is one of the limit enzyme steps in glycolysis, and glycogenolysis is associated with Tori's disease, which is GSD type 7, and 7 and 5 are muscle disorders. So that brings us to a group of disorders that we know of, and predominantly there's the hepatic with associated hypoglycemia, hepatomegaly, and growth retardation when poor metabolism occurs. And then we have the predominantly muscle, which is Pompe, the only lysosomal of the GSDs, and then GSD5 and 7. And then I'm going to remind you that Fanconi-Bickel syndrome is a transporter defect. It was in the past named as a GSD disorder, but that was a misnomer because it's a glucose utilization transporter defect, not a metabolism. I did not mention it in the cycle for metabolism, so it's not part of the glycogen metabolism itself. Fanconi-Bickel is important and unique because it's associated with a significant renal tubular acidosis phenotype where the patients develop features of rickets and so forth. So for the hepatic GSDs, I just want to remind you that we have some that are predominantly ketotic, and those ones are GSD type 0, type 3, 6, and 9. And then we have one that is on the hypoketotic end, and that is GSD type 1A and 1B. And then we have the glucose utilization defect, which is due to the GLUT2 mutation, and that's Fanconi-Bickel. And again, it's not a glycogen storage disease, but it's lumped with them. For glycogen synthase deficiency, I just want to remind you, it's called GIS1 when it's associated with the muscle disease, and that is muscle GSD0. Loss of function mutations in the GIS1 is going to lead to the muscle enzyme being deficient. That's going to lead to skeletal, muscle, and heart disease, and it can lead to myopathy and cardiomyopathy with exercise intolerance, and hypertrophic cardiomyopathy and sudden death. And it's very rare, but you can see it, and it sometimes comes up on exome sequencing when you're looking for patients with muscle disease and myopathies. And then I'm going to talk about GES2, which GES2 is GSD hepatic type 0, okay? So GSD0 is unique. All of these disorders, by the way, except for GSD type 9, are, autosomal. GSD9, one of them is X-linked, but there are also recessive forms. In case of GSD type 0, you want to remember, and that's very, very important, is that these patients have fasting hypoglycemia, but have postprandial hyperglycemia because they can't utilize, when they have a synthase defect, they actually are not forming glycogen. So the problem is when you give them food, they have postprandial, both hyperlactatemia as well as hyperglycemia. It's not handled that well. And then at the same time, fasting is a problem. So hypoglycemia fasting, hyperglycemia, and hyperlactatemia postprandial. The other problem that you have, which makes it unique, is that there's no hepatomegaly. So that becomes a problem in terms of you're saying, oh, I have to look at the liver, I'll do an ultrasound and see if it's GSD. This is one of the GSDs that are tricky because the liver is not enlarged since there's no glycogen synthesis and glycogen does not, deposit there. So these patients can be picked up if you, screen them appropriately during a fasting and then a postprandial incident. It might give you an idea about these disorders, but the hallmark is there's no liver glycogen deposition. So even with a biopsy, you won't see that. The other thing is that molecular testing is important for these patients because some of these patients come with a diagnosis based on the fact that they're ketotic hypoglycemia, and that is not true. You have to have a mutation testing that is positive to find it. Go to whole genome if you have to say, okay, I've done the best and I've depleted all my resources in terms of testing. But definitely this is a disorder not only, again, there was a mention that it's all ketotic patients with hypoglycemia have GSD0 until proved otherwise. I would say actually be careful about that because some patients end up getting cornstarch for no reason and are mutation negative by all testing. So I would say be careful about putting a patient on cornstarch, especially if they're in the age of idiopathic ketotic hypoglycemia until you do a workup and you see that there's no reason for that, and basically try to explain and educate the family about that because it is a problem that there's a misdiagnosis about this disorder. So GSD0 is due to liver glycogen synthase defect. Ketotic hypoglycemia with, can be associated with the symptoms of drowsiness, fatigue, and there's no hepatomegaly. As I've mentioned, hyperglycemia and hyperlactic acidemia can occur postprandially. And then the treatment is similar to other ketotic hypoglycemias that we know of, which is frequent meals and snacks, protein-rich feeding, and uncooked cornstarch at nighttime. I've not seen too many patients, although I've tested so many for it, to rule out the possibility in patients with ketotic hypoglycemia. It's also important to make sure that the pregnant females who have this condition are on a good dietary plan. So for glycogen storage disease type 1, that's the most common one. The incidence is about 1 in 100,000 births. Approximately, it's 25% of all GSDs diagnosed, and GSD1A is more common than 1B. We see that, the enzyme mutations are different. So, that's very important because the new therapies that are coming are specific to the, gene defect that is there. And when we look at, the types of gene therapies that we have right now, editing is even looking at specific mutations. So it's important to keep that in mind. The problem with this disorder is it's the most severe when it comes to hypoglycemia, fasting hypoglycemia, because they have a lack of both glycogenolysis and gluconeogenesis. So they are solely dependent on the cornstarch doses, the frequent meals, and the snacks you give them, okay? And the other problem is, when they have hypoglycemia, you have to keep in mind that it can happen very fast, and it drops so fast to a point that these patients can suffer. If it's at a 50 or 60 mark, it can go down to the 30s, and they can have seizures and coma, and if that's prolonged, it can lead to death. Glucagon in these patients is high in the blood, but it's ineffective, and that's why we never use it for treatment of hypoglycemia. Insulin is very low, and it's suppressed by the high glucagon. So that ratio that I showed you of insulin to glucagon, usually it's reversed in these patients. Glucagon is higher than insulin, but it's, again, glucagon ineffective, and insulin peaks like crazy once these patients eat. So if they eat a simple sugar, the insulin is going to peak and bring it down. So that's why we say complex carbs is the treatment and the way to go. Ketosis is not common in GSD1, and high concentrations of glucose 6-phosphatase generated are shunted into alternative pathways, causing hyperlactatemia, hyperlipidemia, and hyperuricemia. So this, figure shows it very easily, is that when you have a problem in glucose 6-phosphatase and you're missing the enzyme of the, the complex enzyme, In that case, you're not forming glucose, and the substrates, which includes the glucose 1-phosphate and so forth, will spill into the other pathways, leading to hyperuricemia when it goes to the hexomonophosphate shunt, or if it goes down through glycolysis into pyruvate, which increases the lactic acid. And with that, you're also going to see alanine elevations. You're also going to see that there's increase in acetyl-CoA, which leads to, in this case, more of the breakdown of the fatty acids and hyperlipidemia. So it's important to remember that the shunting is associated with hypoglycemia, and these are part of the metabolic control parameters. So when you have a patient under good control, you are making sure that the lactate, the triglycerides, and the uric acid are within normal ranges as well. Interesting enough, the hyperuricemia actually can worsen with high protein. So this is a GSD that you want to give the recommended daily allowance and not go beyond that. And there's a kind of a unique competition at the level of the kidney between lactate and uric acid. So if the two are high, you're going to have delays in the levels coming down, and you want to make sure that hydration is intact so that they both come down. For GSD1 clinical features, of course, with poor control, they can have growth retardation and delayed puberty. And then when you feed them too much, they will become obese. So you have to be careful about that part too. And then, they do have that doll face appearance, and it, looks like the Cushingoid type of facies. They can have abdominal distension due to the hepatomegaly, and a lot of that hepatomegaly in GSD1 is actually steatosis and fat deposition rather than glycogen. They do have some glycogen, but it's mainly fat. And then hepatomegaly and nephromegaly, remember that 75% of metabolism of glycogen is in the liver, about 25% of metabolism is in the kidney, so both enlarge in this disease. They can also have anorexia, weight loss, and vomiting, especially if, the children are not feeling well and they don't want to eat and so forth. So it's something that requires that we put in a G-tube for these patients. They can have some hypotonia, they can have significant bleeding tendencies, nosebleeds, and so forth, and easy bruising because of an acquired von Willebrand's factor disease, as well as platelet aggregation defects when they are under poor metabolic control, so not when they're doing well. And this is just a picture of the liver biopsy where you can see the vacuoles and the steatosis that occurs in these patients, as well as the significant hepatomegaly and the fullness in the cheeks that these patients tend to have. So for other features in terms of GSD1B, these patients also develop, neutropenia, so that's in 1B, and neutrophil dysfunction, and they are at risk of frequent infections in the respiratory tract, the skin, and the genital and urinary tract. It's important to look at the genital area before saying, oh, there's nothing and there's no ulcers in the mouth. So watch out about the mucous membranes. They include the genital tract as well. Sometimes even in the buttocks area. They also can have deep abscesses in the brain. So I have had one of the children developed a mastoid inflammation, and mom sent me a picture, and it widened, I will tell you, in a few hours. And we had to send that patient to the hospital to be evaluated and make sure that, the mastoiditis does not evolve into any brain abscess or anything like that. So these things are very important to make sure that when they say that there's something wrong, look at them. Perioral and perianal infections, look at them. Protracted diarrhea and inflammatory bowel disease because they have a pseudochronic disease-like manifestation. And there's also increased risk of autoimmune disorders. For example, hypothyroidism is more common in GSD1B than 1A. For the complications, dietary treatment improved the survival. So we see more patients over time. Right now, the natural history has prolonged. But we also, in the patients who are not under good control, we also see the problems that can happen with them. So in the past, when patients were not under good control, the main thing were they would develop kidney stones, they would have nephromegaly and hyperfiltration, ending up with renal disease. They also can have a renal Fanconi-like picture. So this is one of the disorders associated with renal tubular acidosis. Hepatic adenomas and hepatic cellular carcinomas. Hepatic adenomas is a big thing. It can start as early as puberty, and it's associated with an increased risk of triglycerides, which is more than 600 milligrams per deciliter. So try to bring the triglycerides down. And then some patients will develop hepatocellular carcinoma on top of the adenoma, and the sign of that is increasing the size of the adenomas above 5 and 6. In that range, you have to do a biopsy because that may suggest that there may be also a carcinoma on top. And it's also one of the conditions that, is associated with the transplant indication. Osteoporosis, because these patients have poor absorption in general of some of the minerals, including vitamin D, and you have to supplement these patients and check them for vitamin D. They can also have chronic anemia due to multiple factors, including chronic disease as well as hepcidin expression on the adenomas, leading to iron deficiency anemia. Pulmonary hypertension used to happen in the past when these patients were very poorly controlled. Acute pancreatitis occurs in the presence of high triglycerides, and polycystic ovarian disease is one of the things that can happen to females, especially when they're on the overweight end, but they can still become pregnant on top of it. And then gout, of course, because of the hyperuricemia when it's elevated in high levels. The workup in general for any patient who is thought to have GSD1 is to rule out during hypoglycemia endocrine causing factors. I just want to make sure that many of the endocrine causing factors are usually associated with, again, hypoketotic, because insulin leads to hypoketotic. So hyperinsulinism, let me be exact, leads to hypoketotic hypoglycemia. And some of these patients have mistakenly been diagnosed with growth hormone deficiency. So, it's important to, reinvestigate if there's a hepatomegaly in a patient who was previously diagnosed with growth hormone deficiency. You can check the serum free fatty acids and beta hydroxybutyrate levels, which is part of the workup that these patients have when it comes to the hypoglycemia workup. You can check lactate, uric acid, and triglycerides. So that's the main thing for GSD1. This usually is tested by endocrine, and when you look at it, it will show you, that these patients have high free fatty acids, but ketones tend to be low. And these are the metabolic parameters that we look for. So lactate can give it to you, uric acid and triglycerides. Besides that, favors again that these patients the patient that you're seeing has GSD1. Liver functions can be abnormal, but not always abnormal. Okay, for GSD3, 6, 9, liver functions are more abnormal. So GSD1, the liver functions can be normal. You check CBC with DIF, especially for GSD1B, because these patients can have neutropenia, and the absolute neutrophil count can be abnormal. They can start with normal white blood cell count and then develop neutropenia. So I just want to say the neutropenia may appear later. Iron levels, including TIBC, ferritin, and vitamin D, should be checked yearly in the follow-up. Urine microalbumin and creatinine should be done randomly, especially near to the age of puberty and ongoing, and earlier if the patient's under poor control. Urine amino acids, electrolytes, and phosphorus when there's a concern about renal tubular acidosis. And you can do liver ultrasounds in children or MRI and CT in adults, especially if there's an adenoma. And then the GSD1B, there's some markers that we use, CRP, GI studies, and I'm going to talk about another marker later when we talk about GSD1B. It's important to remember that frequent feeding is the main thing for these patients. That's the treatment. So you have to provide a constant source of carbohydrate sufficient to maintain the blood sugars. For newborns and infants, of course, the GIR to maintain them, to have enough blood sugar is going to be higher and variable based on the amount of glycogen stores. So for newborns, it's about 8 to 10 milligrams of glucose per kilogram per minute. And in infants and younger children, that level can go down to 5 to 7 milligrams. In older adults, and remember, adults are not children, so 4 to 6 max, okay? Because lactic acidosis is actually a risk in patients who take a lot of glucose infusion, because simply adult livers cannot handle too much glucose. So this is an adult thing, not a GSD. So GSD poses the risk. They can have lactate elevation because of GSD, and then you give them the risk that the liver can't handle too much sugar because they're adults, worsens it. They should have an ER letter that is provided for emergencies. These are patients that should not wait in the ER for any reason. And then the medical bracelet with an indication for an alert for hypoglycemia is highly recommended. For the dietary guidelines, we say small frequent feeds that are high or rich in complex carbohydrates, evenly spaced over the 24 hours is our goal. 60 to 70% of the diet should be coming from carbs, and about 10 to 15% from the protein, and the remainder coming from fat. If the triglycerides are high, watch out from saturated fats and so forth. But if you keep everything in a balance, these patients do very, very well. I personally restrict the simple sugars. I know that there's a variation from one provider to the other, but it's very nice to start it in these children when they're young so that they don't get used to, the sweets and the sugary taste. And, watch out for fructose, and watch out for galactose, so simple sugars, and watch out for sucrose, because those are the ones where basically if you give them the fruit in if it's not a low glycemic index fruit, something like a simple sugar candy or anything like that, or anything that has added sugar, which is sucrose, you're going to have an insulin peak, and the blood sugars are not going to keep until the next meal or the cornstarch dose. So you're actually doing the patient and the provider a service by preventing the risk of hypoglycemia that happens due to hyperinsulinemia simply because you're choosing the wrong sugar. And it's important to remember that, again, if you give them something like fructose or anything that breaks down into lactate, so simple sugars break down into lactate, these patients are not going to break it down to glucose. In this case, it's instead going to be shifted into lactate. So do not do that. I mean, it's highly recommended if you see that the lactate is elevated in these patients. Avoid simple sugars as much as you can, And then feeding is every 2 to 3 hours during the daytime for the infants and the younger children. I usually choose a sucrose-free, lactose-free formula. So you can use soy formula or Nutramigen or anything else. And then the overnight feeds are important, and this is going to be through a G tube. Sometimes, families start with an NG tube, but then, handling an NG tube is not easy, and the risk if something goes wrong is high. So G tubes are helpful in the early stages, and, based on the age and what you want to do, you adjust the GIR of the glucose infusions that you're giving at nighttime. So working with a metabolic dietitian is very helpful. Glucose monitoring is highly recommended in these patients, whether it was by finger sticks, and now the Dexcoms are used for even children who are very young in age. So that would be another way to monitor the blood sugars. And then start introducing the baby food at 4 to 6 months, advance in a timely manner, one thing after the other. Make sure that the babies tolerate that. Choose and emphasize the complex carbs. You've got oatmeal, barley, rice, pastas, legumes, and so forth. And it's important to remember that these complex carbs are maintain the blood sugar, at least for ranges better than, for example, potatoes and bread. So uncooked cornstarch, when should it start? It should start by 12 months. And I'm saying that because that's the age where the pancreas gets mature enough, the amylase, to be functional. So if you start it earlier, it may be associated with diarrhea, but you can start earlier, for example, around 10 months with a smaller dose. So say half a tablespoon, and see how they tolerate it. Okay, so it's nothing that you can pose on the patient without carefully regulating. And you can try, as I said, with a low dose and start low and then go up very slowly, because these patients can have gas, bloating, diarrhea, and it can worsen the type GSD1B if they were not under good control. And then what you want to do is gradually introduce it so that you may reduce the side effects over time. And then for patients who are not doing well, despite, that they're in the right age and, taking a gradual intake of the dose and the dose is just not working, you can try giving them pancreolipase or enzyme, pancreas enzymes to help them. And that goes through GI, by the way. The dosing of the cornstarch, so about 1.5 grams, 1 to 1.5 grams. So again, the dosing may be variable from one patient to the other based on the body weight. And I would say taking the ideal body weight if the baby or the child is on the obese side, and check out how long that's lasting with you. And it should be every 3 to 4 hours in young children, and then 1.7 to, again, I'm going to say 1.7 to 2.5, anything in between that works for the patient, every 6 to 8 hours in older children, adolescents, and adults. So I'm saying that it's not by the book, you have to give this amount. It's depending on the patient's needs and how much they can tolerate. For adults, just remember that the GIR should be within the 4 to 6 range, and adjust based on the glucose. And in these patients, you're not trying to make them hyperglycemic, you're just trying to maintain normal glycemia. So remember that as well. Every patient is different than the other, so individualized therapies are important based on the blood sugar levels, as well as based on the tolerance. And it's important to remember that cornstarch in general will ruin if it's exposed to heat or moisture, and if it's given with ascorbic acid, vitamin C, or citrate, or lemonade, or any of that, because it limits its absorption. So space it away. So I'm not saying prevent or, do not give, I'm just saying space it away. For modified cornstarch, which is our glyphosate that we know, if you look at it, so it came and revolutionized the nighttime cornstarch doses for patients who are able to tolerate and are ready to take it. And the reason behind it is because it has a higher amylopectin content, so 99 versus 72%. And the conventional cornstarch here is Argo cornstarch, which is the common form that they use. You can see also that the biggest other difference is the glycemic index. That glyphosate has a glycemic index of 30 versus the conventional of 70. So it lasts longer because it does not allow an insulin peak to occur. So you have a more stable plateau of the glucose in the blood without a spike of insulin that brings the blood sugar down. This was based on randomized trials. So in the past, they did the randomized trials in patients at the age of 5. I know in Europe and so forth that they've used in Australia and Canada, they've used it in younger patients with the different type of GSDs. And I personally have used it in younger patients with different types of GSD, not GSD1 per se, but in the younger patients with GSD type 3 and type 5, I've used it and it has worked. Other treatments for GSD1, you have to give them multivitamins and mineral supplements, and that making sure, again, if they need iron, so you're checking their ferritin and iron levels throughout the year. So once a year at least, you're checking their vitamin D at least once a year. If they have hyperuricemia, for example, uric acid more than 10, then and persistently more than 10, you want to add allopurinol to prevent the risk of gout and stones. GCSF for the patients with GSD1B and neutropenia. Right now, the GCSF, is being replaced by the newer drugs, which is SGLT1 inhibitors. Jardiance is the name of the drug, and I'm going to talk about it later. And then citrate is used for patients with stones because these patients tend to have low citrate, and citrate, when it's low, increases the risk of stones. And patients with renal tubular acidosis, again, can get it for that reason, for the acidosis. And again, the main thing is space it away from cornstarch. ACE inhibitors and ARBs are important because these patients develop proteinuria. That the earliest sign is microalbuminuria, so when they have this hyperfiltration, they need to be placed on it, even if their blood pressure is within normal, just like we do in Fabry's disease. And then liver transplant plus minus kidney transplant. If the kidney is affected, if you add the liver plus kidney, you basically are curing the disease, because those are the two main organs affected in GSD1. And patients who've received kidney first, and after that, continued to have the liver in and had problems, because when you give a kidney transplant, basically some of the immune suppression medications can ruin actually the effect of the liver and cause hyperuricemia and stuff like that. They ended up getting a liver transplant after that. So I just want to say, if the kidney is the first to be impaired, liver kidney is a good idea. Combined will be curative, but of course you have to be aware of the immune suppression risks and so forth. So the indications for liver transplant in GSD1 are hepatic adenomas, carcinoma, poor metabolic control with lack of compliance. Some patients that have had pancreatitis repeatedly and just are not coming down, and they're not compliant with the diet, and there's no other way to fix it. You may consider a transplant. In this case, knowing that if that is the choice, they need to be compliant with transplant. They need to understand the consequences of diet versus immune suppression. They need to understand the difference of that, especially in patients who are of the younger age, and when the parents have to be involved in that discussion, and it becomes a task to make a decision. So this is one of the updates that I have, and probably you already heard about the transformation that has occurred for patients with GSD1B and neutropenia, is that they've repurposed a diabetes drug, which is empagliflozin. I pronounce it badly, so that's why I've been saying Jardiance, for GSD1B, and it is an SGLT1 inhibitor. The group that has worked on that has published multiple papers since this one. So you can follow them and follow what's been going on with that. The whole idea is the patients with the transporter defect in GSD1B will accumulate a product that is toxic called 1,5-AG6P. And that product that is toxic builds up, here's where the defect is, builds up right before the defect. And you can see here that 1,5-AG is a marker or biomarker that kind of is increased when this increases. So this biomarker is not toxic. This is the toxic effect that accumulates. The toxic product that accumulates suppresses hexokinase as well as other enzymes involved in the metabolism of the neutrophil and the neutrophil function. So it leads to the neutropenia as well as the dysfunctional neutrophils. So when you give that treatment, and the treatment should be started in patients based on their age and so forth, it actually improves both the neutropenia as well as the neutrophil dysfunction. So this repurposing of the drug came in from diabetes, and I just want to say it does reduce the 1,5-AG6P by adding the SGLT1 inhibitor, and you can see that reflected on a lower 1,5-AG in these patients. Then continuous glucose monitoring has come in really big time with these patients, and now it's easier to get it for our patients. They've been using it, and it's been updated so many times. Now it's the G7. I hope I'm getting it right. 7, but some patients at many it still have 6. I hope I've got the numbers right. But anyway, with more technology, it has better. It's supposed to be needing less of the standardization and being affected less by the Tylenol and so forth doses, and being easier to place and to upload and stuff like that. So it's just an important thing to use in these patients because it has allowed them to be more liberated from finger sticks, and they get an alarm when they're low. So it's kind of been a very helpful device for monitoring these patients, both on the clinical end as well on the research end. So CGM in patients with GSD type 1 look like this. So just to show you that, you know, it's a sawtooth-like appearance. And it's because when they eat something, insulin goes up and brings them down. They eat and then insulin brings them down. So you can see that pattern. And what we like to see is that more, it tends to have a straight line over time with better therapy and with more complex carbs getting added into it and with the cornstarch. So we like that pattern to improve. We like the patients to be in a better range where they're not having spikes of hyperglycemia nor troughs of hypoglycemia. It's important to use the ideal complex carb, those that are breaking down slowly, that do not cause an insulin peak, and those are the ones with the low glycemic index. So you have to kind of be informed about that word and term and what those diets are. And the non-ideal are the simple carbohydrates, because these are going to lead to that saw-tooth appearance, which leads or comes from the rapid rise and drop in the blood sugars. How high the blood sugar rises after meal and how long that lasts and so forth depends on the glycemic index and the glycemic load. Using both are useful, but at least know about the glycemic index, because it offers choices, and there are now like apps and things like that and sites on the websites that give you an indication of what the glycemic index is of the food and the bread and the stuff that the patients are eating. So what is considered a high glycemic index? It's more than 70. And I'm not going to talk too much about the load, but I'm going to focus here. And then moderate is from 56 to 69, and then low is less than 55. So the lower is the best for patients who want to maintain their numbers between one diet, one meal and the other, or one meal and cornstarch. The high is needed when the blood sugars are very low and you want to bring them up high. The moderate is the one in between. So say the blood sugar is in the 60s, you can give them a moderate and it will last longer and it will bring their sugar back up sooner. If the blood sugar is in the 20s or 30s, you want to give something that is a high glycemic index. And glucose is 100, by the way, so it's the highest. So when we put them on the glucose infusion, they immediately go up for that reason. And just a reminder is, if the infusion gets disrupted due to any single thing, they will drop immediately after that. So this is, again, how you can see what happens with the high glycemic index foods is it comes down basically because the insulin peaks. And you can see if you have low carb, low glycemic index, how it's less fluctuant and the numbers are more stable in terms of the glucose normality. Okay, and I'm just going to pass through this a bit fast because I know that time is running, and I just want to let you know here that when you're designing for them to eat, if you tell them that they should start with the protein before they start the carb, that is a good idea, because that allows, again, less of a spike by insulin when they start the meal. And then eating vegetables and proteins first, so if they you say, well, he doesn't like to start with the protein, you can start with the vegetable first and then go to the carbs. And it's very important to remember that, again, the complex carbs are better. Pasta, if you cook it, not well done, so al dente lasts longer, actually. So if it's more crunchy, it lasts longer. So just a few hints that the dietitian can give. And then there are lists with the glycemic load and the glycemic index for different foods. And then I'm going to go through GSD type 3, and I'm going to go through these faster right now because we know what the baseline is in terms of GSD. So debranching defect is deficient in Cory's disease or GSD type 3. 3A, unfortunately, is more common than B, and I'm saying that because A is the one that can be associated with muscle and heart disease and is the more severe one to treat. Fasting ketotic hypoglycemia is the key, and these patients also can develop postprandial hyperlactatemia, similar to GSD 0 in that part, but not postprandial hyperglycemia. GSD3B is predominantly liver disease, so you can think about it. These patients have a structural defect in their enzyme. So the branching enzyme and debranching lead to the breakage of the tree and the forming of the tree. So branching, forming, and debrancher, the breaking, and the structural abnormality adds an extra thing to the pathogenesis of the disease. So hypoglycemia is one thing, and you may say, oh, but they're not that hypoglycemic all the time. But they have another problem. The structural abnormality leads to deposition of an abnormal structure of glycogen in the liver, leading to liver dysfunction. So these patients can have actually ALT, AST elevations, and when they have GSE3A, it can also be associated or higher because of the CPK, which can be caused by the muscle disease. The hepatic fibrosis, cirrhosis are mainly the reasons why these patients end up having liver damage and need a transplant. And if it was B, it's curative because their only problem is the liver. But if it's A, it's a problem because the liver transplant is going to lead to giving medications, and immune suppression medications, believe it or not, can actually worsen the muscle and the heart disease. So we try as much as possible to treat these patients with A as much as we can. One of the ways to do it is, of course, high protein. But anyway, elevation of the CK and hypertrophic cardiomyopathy and the risk of arrhythmia and sudden death are real in these patients, and they need to be followed by cardiology. The treatment is, again, frequent feeding, but the difference is big because cornstarch here should be lower than 50% of the total amount of calories, and the amount of carbs should be, again, less than 50% of the total amount of calories. They should have a high protein diet, up to 24 or 30% of the amount of the calories coming from, proteins and so forth. The amino acids, can be followed because when you give high amino acids, you're always going to say, what about the kidney? So check uric acid if you're worried about the kidneys. But then the other thing is the reason why they can make and use the amino acids is they have preserved gluconeogenesis. So they can use that for a source of glucose formation. Unlike GSD1, who don't have that. Cornstarch, when indicated, remember that too much and too little are detrimental, so you have to give the Goldilocks dose, and that is going to be a matter of every patient. That is different than the other, but you're going to kind of bring it down. So this is one where basically on a ketogenic potential might be better, so lower carbs. And then liver transplant when there is cirrhosis or adenomas or malignancy and it's curative in GSE3B, not A. Brancher enzyme is GSD type 4, and mutations in GBE1 or the brancher enzyme leads to another deposition of an abnormal structured glycogen that leads to both the qualitative defect here, and some patients are so-called have hypoglycemia. It was thought to be secondary to the liver failure. Some patients are having hypoglycemia outside of the liver failure, so it's something important to observe in these patients. Because the abnormal glycogen is an insoluble type of structure, it's called the polyglucosan. It resembles a myelopectin, and it can involve the liver, the heart, the muscle, and the nervous system. For Anderson or branching enzyme defect, these patients can be normal at birth, and then they start to have the organomegaly. And these patients can have portal hypertension with significant splenomegaly. And then they also can have, of course, poor growth. And if they have the liver disease, they need a transplant as soon as possible. Main thing is make sure that the heart is not affected, because some of these patients can also have a cardiomyopathy and glycogen in the heart. And then if you do the transplant and you don't pay attention to the heart heart disease can worsen. So it's important to work with both in mind, making sure that you make decisions that are going to be helpful to save these patients and not cause worsening of their disease. These patients can have very abnormal liver functions and coagulopathies, and all of that can be their first presentation. The important thing is to remember that the liver biopsy can be diagnostic in these patients. So if they have hepatic picture that can be cirrhotic, but the periodic acid shift, so that is the indicator or the stain for glycogen, is positive but diastase resistant. And that's because the glycogen structure in this case is a polyglucosan body and not normal glycogen. So normal glycogen stains positive for periodic acid shift. The structure of a polyglucosan body is diastase resistant. So it's important that they look into that part when you ask for a muscle biopsy, and they'll see by electron microscopy also the characteristic features on the biopsy. So this one can be given out by biopsy as well as mutation testing, of course, which is less invasive. The treatment in these patients, you have to be careful about the amount of carbs you're giving, again, because of the abnormal structure. But at the same time, they need a liver transplant or liver and heart transplant if the heart is affected. Adult polyglucosan disease is a late onset form, and there are common mutations in the Ashkenazi Jewish population, but there are also other pan-ethnic mutations. The symptoms start in adulthood, and it's characterized by myopathic or neurogenic bladder and spastic gait, weakness in the lower extremities, progressive peripheral neuropathy, not really liver disease at all. But it's important because it's a progressive debilitating disease, and it leads to accumulation of these abnormal glycogen structures in the nervous system and the spinal cord. And at this point in time, there's no specific treatment, but there are drugs developing in that area as well. For GSD type 6, which is due to, other name is HERS disease, it's liver phosphorylase deficiency. These patients have hepatomegaly. They can also have growth deficiency. And again, treatment here is high protein, cornstarch as needed, and frequent meals. GSD9 falls in the same category of 6 and 3 is ketotic hypoglycemia. These patients also require monitoring of the liver functions, just like all the ketotic hypoglycemias. And it's important to make sure that, hypoglycemia and ketones, if you're able to monitor, are looked at as well. These are some practice paper guidelines that are very important. So we have for GSD type 1, we have for GSD type 3, although we're hoping to renew. And then for GSD, we have 4 and 6. And then I'm going to talk a little bit about Fanconi-Bickel, simply because, again, it's a glucose utilization defect. And these patients have a hepatic, intestinal, and renal glucose galactose transporter defect. So this is one of the groups of patients who can show galactosemia positive, by the way. They present with hepatomegaly and tubulopathy, and the renal tubular acidosis is, very, very evident. So these patients can show with hypophosphatemia and rachitic manifestations be their first finding. They're ketotic hypoglycemia again, and they can have, fasting hypoglycemia. The treatment is mutual, so you're going to have a multidisciplinary relationship with the nephrologist and the endocrinologist. They're going to need, calcium, vitamin D. They're going to need replacement of carnitine. I just want to add that, a new thing that I learned about in the last Association for Glycogen Storage Disease meeting is that the Dutch group have used the SGLT1 inhibitors for these patients, and it has improved the renal tubular acidosis. So it's something to consider if you have a patient with this condition, and if you need, some guidance about it, I'm happy to connect you with the group that is involved, and we always try to guide each other here. So for GSD type 5, one of the muscle diseases, it's myophosphorylase deficiency. Remember, again, you have a problem with muscle glycogen metabolism here, so it's going to happen during exercise. Usually it happens early in exercise, so different than the exercise intolerance and the myoglobinuria or the rhabdo that occurs with fatty acid oxidation. So this happens early in exercise. These patients are going to have a CPK elevation with rhabdo and muscle pains, and they have something called the second wind phenomena, which is if they sit down and rest, fatty acid oxidation is going to kick in, and they're going to be able to resume the exercise after resting. And because of where the defect is early on in the glycogenolysis pathway, it's okay to give these patients glucose. They handle it well, and actually they go back and do better when they have some sugar on board. The diagnosis is by mutation testing. And remember that there's a targeted mutation for Caucasian that does not pick up the rest of the patients. So full sequencing or using a panel might be better in this case. And it's important to make sure that you regulate that these patients have snacks at the time of exercise, and then at the same time that they listen to their body and they stop when they need to. Another thing is ketogenic diets have been brought up and have potentially been helping some of the patients. So it's something to decide on based on the patient and what they're doing and their weights and things like that. So not every patient it's going to work for them, but it's just look at the literature when you're in question. GSD type 7 or Tyrese disease, that's muscle phosphofructokinase deficiency, which is type 7. This is a limit enzyme in the glycolysis pathway, and it's lower down close to the pyruvate end. So I just want to say it is very characteristic or unique because it's also associated with a compensated hemolytic anemia. And why is that? Because the RBC does not have mitochondria. So it's dependent on glucose for energy. And when you have a problem with this enzyme, there is none, and the patient develops a megaloblastic, so MCV will be high, and the retics will be abnormal in these patients during these incidents when they have rhabdo as well as the exercise intolerance. So they can have a hemolytic-like picture. They also can have progressive myopathic pain, again, and exercise early in the exercise phase. Instead of a second wind, they have something called out of wind. And that is because if these patients rest, there actually is too much glycogen in the cytoplasm and nothing goes to the beta oxidation. So they end up having inhibition of fatty acid oxidation due to the abnormal glucose in the cytoplasm, not sensing that there's a problem. So they go out of wind. They don't do well. So what is the treatment? Give them something that has protein. Give them something that has fat. Do not give them glucose. They do not handle glucose well. This is one of the patients or one of the patient groups that should not get a glucose infusion. So PDH, pyruvate dehydrogenase, since I give that talk, as well as Tori's disease should not get glucose infusions. Avoid simple sugars and avoid glucose. You can give them normal saline. You can even give them Ringer lactate, believe it or not. This is one that can get Ringer lactate because it's a glycolysis defect. They don't even form lactate. So you're good with that one. So we also have some guidelines for GSD type 4 that are published, as well as for GSD 5 and 7. And then I'm just going to talk about GSD 14 and glycogenin defect, just because 14 and 15 kind of come up due to interest. So 14 is the GSD that is known also as phosphoglucomutase deficiency. It's considered a CDG as well as a glycogen storage disease. It has a predominantly muscle myopathy form of disease, as well as multi-system involvement, including congenital anomalies, including cleft palate and so forth. And just a reminder that some of the CDGs have treatment, and this is one of them. And there has been trials for D-galactose in these patients. In terms of the glycogenin deficiency, I'm mentioning it because it's that early step of that first primer of the glucan synthesis chain. And it's coming up right now on many of the panels. And it actually is associated, so this is GSD type 15. It's usually associated with deficiency of glycogenin in the muscles and in the heart. And in the humans, it's thought to be causing, in a recessive form, muscle disease and cardiomyopathy. So these are things that should be looked at, not liver disease per se, not ketotic hypoglycemia, because I know it's been picked up on some patients who have ketotic hypoglycemia. This is something we still need to look into, and I believe Priya is collecting these cases. So you may ask her if you have one of these patients. She might be the right person to answer you back about what's going on there. New therapies for GSD1A, I just want to say that the horizon is increasing for 1A, especially. Right now we have gene therapy, we have gene editing, and we have RNA therapy. So gene therapy, as you all know, is the use of the adeno-associated virus to deliver the functional genes to the liver and potentially restore glucose metabolism. There is a potential for it, and there are ongoing studies, and I will mention it. Then we have gene editing, which is a technology that is using the CRISPR-Cas or different forms coming out of that as adenine-based editing and prime editing. So different forms of gene editing are happening right now, as well as RNA therapy, which the idea is delivery of messenger RNA into the target cell, which is the liver cells here. And then the cell machinery will translate the messenger RNA into a functional protein. So of course, this is going to be a transient type of thing. So not enzyme replacement therapy, but it's like providing the protein that is going to be lasting for a certain amount of time. So right now we are in trials, or there are clinical trials that are trying to estimate what is that right time. So I can't give you a final answer to that. The goal is to increase the levels of the enzymes that are otherwise non-functional in GSD. And for the clinical trials that are available currently and are active, we have the gene therapy AAV8 Ultragenic CTX401 phase 3. It's currently not recruiting, and patients have been dosed, and the results of the data are being presented in meetings. That I'm going to stop there. And then for the messenger RNA trial, the Moderna trial, we have different phases. This is phase 1-2 that we still are recruiting for. So there are multiple clinical trials in different areas in the US, as well as I believe they're going to be starting in Europe as well. They have a single administration dose trial for each of the doses that they're choosing to start with, and then a multiple administration dose. And they currently are recruiting for patients for both ends, the SAD for the third dose or the higher dose, and then MAD, which is the multiple administration dose for other patients. Emerging therapies that are preclinical, there's splice switching oligonucleotides based on therapy, and these are used to treat type 1A GSD. And I just want to say there are other, editing tools, and one of them is the adenine base editors, and Beam Therapeutics is working on that one. And I believe it's on a specific mutation that is common in the Ashkenazi Jewish. I will mention it. And they will be moving to a clinical trial. I don't know that they've started it. We're not involved, but they will be moving onto a clinical trial soon. And there are ongoing preclinical studies by the Jew group as well that, again, are on mouse spaces right now. So very preclinical. For the emerging therapies for GSD1B, we know about the SGL2 inhibitors. There's also messenger RNA replacement therapy. Cure GSD1B is focusing on that. This is preclinical at this point in time, so no human clinical trials. And they're collaborating, to find better ways to propagate this study. Prime editing for GSD1B is another way that, they're advancing prime editors. So this is another way of basically using CRISPR-Cas and editing. And the prime editing, again, is selective to certain mutations. So they're looking for one mutation, specific mutation that they will be treating. In terms of GSD3 therapies, there is a study that was started and recruited patients. That was the Ultragenics messenger RNA therapy for GSD3. And I believe it was a phase 1-2 trial. I was not involved, so I can't tell you any details about that one or where it is, but it currently is not recruiting. And then there's preclinical GSD3 study, which is by Genethon, and they developed an innovative gene therapy strategy for GSD3. They designed a truncated functional version of GDE that can be packaged and transported to the disease cells. I just want to say something about this enzyme. Debrancher is a huge enzyme, so it can't be packaged easily. It's been a problem, and it's a major challenge. Okay, so here, what they did is they had a way to try to package it, and they packaged it in a mini form. So they minimized and chose certain areas that they thought would be important for the making of the enzyme, but it worked on the muscle, it didn't work on the liver. So we should wait and hear what's going on with that approach, okay? So it's hopeful because it improved the muscle disease, but what it was made for was primarily for the liver, and that still requires, they're still working on that to correct the liver glycogen other than the muscle and heart. Okay, I'm going to talk about liver transplant in GSD1. I want to say that it is, not recommended as the first therapy, and simply because would you choose a procedure that involves immunosuppression, so a procedure meaning surgery, major surgery, and immune suppression, or a diet, even if it meant that that diet would be the whole life and there's a commitment to it and so forth? Usually, mostly, most patients will go by the diet first. The point is there is an indication for transplant for patients with GSD1, and that should not be delayed. If the patient has huge adenomas or adenomas bigger than the size or increasing size of adenomas or increasing number of adenomas, despite of control, even though you're controlling, or you can't control and it's very hard, these are patients that delays should not happen. You have to bring up the liver transplant discussion, because if the size is more than 5 or 6, there can be spontaneous rupture in the adenoma, and that will lead to an emergency bleeding in the abdomen. And then the other thing is, if the size goes more than 6, there's an increased risk that this has changed to cancer, carcinoma. So it's important to remove that, big one, and do biopsies from it to make sure that it's not malignant. There's bleeding risks and there's poor metabolic control that can be associated with severe disease. So you have to bring these patients under control before even considering transplant one way or the other, or else you're going to have a very difficult procedure. But it's very important that to know or remember that some patients, despite you try and you try and you try, they just don't comply, or they have problem with access or poor access to care and so forth. And you may want to consider transplant in those patients as well. There are other treatment options for adenomas, and it depends very much on the size of the adenoma and where it is, because some of these procedures can fail in the presence of adenomas at, in different sites and locations, as well as if the size is abnormal. And you always have to make sure that you have a way where if the adenoma is big, that you're going to do a biopsy and make sure there's no malignancy. A combined liver plus kidney transplant, consider it if the kidney disease is the primary organ failure, because it's curative. Basically, you're going to give immune suppression anyway, and basically, if you start with the kidney, it's going to affect the liver. So it might be better to just do the two at the same time and cure the disease. And I said GSD1A, not B, because B has the bone marrow element in association. So that's, and maybe associated with risks and so forth. So that's a different matter. GSD type 4, the treatment of choice is liver disease. And if that is positive, you have to examine the heart by biopsy to rule out the cardiac disease. Echo may show nothing, and then the heart would be still affected. So you have to at least look at the heart by either imaging that can show it, MRI or something like that, if there is a way, and at the same time, the biopsy. And then GSD type 3B, if liver cirrhosis happens in 3B, a liver transplant is actually curative. If GSD 3A, it's risky because of the risks over the heart and the muscle. So we try as much as possible to keep these patients under good control. And I'll stop there, and thank you for your attention. Was I okay on time?
You're fantastic on time. Yeah, it's 1:15. That was an incredible lecture. Thank you very much, Dr. Gharbawy. Questions for Dr. Gharbawy? Can you see the
So
chat?
are there questions? I haven't looked at the chat, so I'm sorry.
No, this is the first one that came up. So for GSD7, Tarui, two questions. One, are you aware of any developmental delay or intellectual disability? And two, can you explain the mechanism by which the fatty acid oxidation is inhibited?
Oh,
It's from
so
Dr. Slater, one of our fellows.
yeah. So what was the first question though? The first one was
Is there any developmental delay phenotype?
in which one?
Tarui?
Tori? So phosphofructokinase, there was a spectrum of phenotypes. Early on, starting with arthrogryposis, actually, which also happens in GSD type 4, which is the branching defect. So there is in the literature some, history about phosphofructokinase and developmental. I wonder if they had the right type. So I would say from the patients that that I've seen, that I've known, that have the form FRUST, the real disease of phosphofructokinase, the muscle disease, they don't usually have developmental delay. They mainly have problems with the muscle disease. As for the fatty acid oxidation disorder, so think about it this way. So phosphofructokinase is a problem with glycogenolysis where the glucose oxidation does not happen. It doesn't end up changing to pyruvate to lactate. So the glucose is never going to get formed in that aspect. So what ends up happening is there is more of, a level of glycogen in the cytoplasm in response to the fact that there's glycogen deposited, but it's not changing into glucose. So an easy way, and I'm just explaining it in an easy way, is it tricks the fact that you need to prompt the change of the glucose down to the mitochondria for fatty acid oxidation to be propelled. So if you think of where, let me go back to the slide of where it is in the cycle versus, I still have my screen, so I will show you this picture and tell you where it is versus, for example, GSD type 5, and that might give you a better idea. Yeah, so here, the phosphofructokinase, the muscle type is right up here. These patients are away from the end side or the limit enzyme mutation here of phosphofructokinase deficiency. And by the way, when you look at this, they will do okay with glucose because that glycogen deposition that's in the cytoplasm is not significant enough to cause that problem. Here, with phosphofructokinase, you have lack of that transformation of glycogen and glucose enough to create ATP for the mitochondria to produce fatty acid oxidation. So what happens is fatty acid oxidation does not occur. It can be associated with the, enzyme changes and so forth that happen when the acetyl-CoA portion is elevated in the cytoplasm. It can be associated with that. And, in that case, it's just not making enough fatty acids. So you don't have energy to derive fatty acid oxidation. I just want to say, because you asked me about the developmental delay. So if you look at phosphofructokinase here, it says in the brain and muscle. So I'm not going to negate the fact that maybe some patients have like a severe form of a deficiency. It may end up to be really, it is a spectrum, and that those early cases that had arthrogryposis and developmental delay part are associated with problems in the brain. But I would say if your patient has developmental delay, look for other reasons and then pin it on phosphofructokinase if you have another factor that is showing that. Like, for example, if the patient has CPK elevations and you fractionate the CPK. Do you remember the CPK fractionation is MM and then cardiac muscle and then brain? So if you see something wrong with that part, you might think of it. I'm just giving you an idea and thought. I can't hold to that being the answer to your question.
Thank you. Thank you, Uri.
But it's a great question.
Any other questions for Dr. Gharbawy?
Any other questions? Yeah, so I guess I can say that I'm happy to type 9A. Yes. Yes, we all have experience, I can say, with 9, and there are different, subforms and isoforms of them. And can you tell me what the mutation was in your patient? I don't know.
Why do you ask, Uri? Is there a genotype-phenotype correlation?
Well, there are some genotypes that are worse than others, and I just want to help. Like, I see that it's a novel mutation from south of Mexico, so PHKAD homozygous. Okay, can you tell Raul? Can you tell me, is your patient having any specific problems? I mean, so it's the same thing for all the types of GSD9. I just want to explain that sometimes people think that it's milder than the other types of GSD. What happens is the hypoglycemia may be milder, but the liver disease, the ALT, AST elevations, is what is the factor. And you're saying hemizygous, so that's the accurate way to say it because it's an X-linked condition. The point about it, so I have 3 or 4 patients that I know, that I follow and I know of, that I've had in the past with X-linked disease. They will do well as long as you've got the hypoglycemia under control, and if you are able to make sure that their liver functions are monitored very closely. So one of the problems with GSD3 as well as 9 and 6 and so forth is sometimes these patients have elevations in the liver enzymes, and then over time you see the liver enzymes going down. So if you see the liver enzymes going down, you're going to say, oh, they're improving. So the point is that can be very tricky because sometimes it can be associated actually with worsening of the liver, and it's reflecting on the ALT, AST. So what you have to make sure of is if you feel that this patient had very high levels, actually, I know it's invasive, but sometimes doing, if you can, a baseline biopsy, if they were doing procedures for any other reason, like if they're going to get a G-tube or anything like that, and keep it as your baseline study, because they sometimes can have bridging fibrosis as an early sign of their disease, even in the presence of hypoglycemia that is under better control. So monitoring the liver functions are important, as well as using an additional tool. So for example, if you have an ultrasound that's associated with elastography or a fibroscan, or an MRI with elastography, something like that, to be able to look at the variation in the liver with imaging over time, because that's going to be an important thing.
Thank you so much. We are struggling with the hypoglycemia, and it was a late diagnosis, 2 years. So I saw him after many doctors, and I say, oh, there's something wrong with this liver. We got the biopsy. The pathology say that the pattern was weird. It was not everywhere, was kind of focal deposit. So I was suspecting that something was wrong. So we ended is this novel mutation. The kid now is almost 3. He's doing kind of well, but he got liver enzymes very high at some point, are improving, but we're still measuring glucose, but capillary glucose, and it's going bad. Sometimes after 6 hours, go down. So we're struggling with the cornstarch. He is not improving weight, and it's my first case for sure. So we don't have the experience. This is the managers together with the gastroenterologist, and we are thinking how we can improve that. That was my question. What is your experience?
Raul, I'm happy to connect with you offline for your patient, but I can tell you we have had patients with exact scenario and they improve very well when you get them on a diet. Does your patient have a G-tube? Does your patient have a Dexcom? Are you monitoring ketones as well as glucose? Because this is one of the ketotic hypoglycemias where ketones can be an earlier sign than the hypoglycemia. So if you're seeing hypoglycemia, that's already a sign, but you have to control both the ketosis as well as the hypoglycemia. So we usually will ask them at the beginning to have a glucose ketometer with them and check ketones as well as the glucose, because we want to look at both and make sure that both are under control. The other thing that's important is this is one of the patients that you need to bring in repeatedly. And just to let you know, this is the kinase phosphorylase 1 mutation is associated with the red blood cells. So sometimes you can get the mutation, the low enzyme activity in the red blood cells, but you already got the mutation, so you're good with that. But I just want to make sure that you know that this is one thing to follow over time closely, because we had a patient, very similar situation. All what it required is bringing him in every 2 or 3 months, making sure that the G-tube, that they get a G-tube, that the diet is high protein. You want to give high protein. And how old is your patient?
3 years old now.
3 years old. So just to let you know, your patient at age of 3 can get a dose of glyphosate at nighttime. So can get glyphosate because it's not GSD1. So he might be stable with a dose of glyphosate at night. And then the cornstarch amount should not be excessive. The key here is high protein. So you have to add supplements that include high protein. You have to add, for example, he can get simple sugars. He can get not the regular simple sugars, but I want to say he can get milk. The milk, you choose the one that has high protein, Fairlife, for example, if that is doable, or a protein, high protein containing meal. If he is he eating by mouth or is he not eating by mouth? Like is he getting?
Yeah.
He did eat. Okay, so supplements and foods that contain high proteins. I'm happy to connect with you, and I can send you my email. I'll put it in the chat.
Yes, I have it. I have it. Thank you so much.
You have it. Send me an email, and I can get our dietitian also to talk to your dietitian as well, if that would help you.
Great time.
Okay.
Another question that popped up in the chat for Fanconi Bickel. Can you use cornstarch along with a high protein diet?
Cornstarch with so Fanconi Bickel, cornstarch with high protein diet. So high protein diet, do you mean add the high protein to cornstarch or give them a high protein and cornstarch diet?
It sounds like they're using the cornstarch or talking about adding high protein.
So high protein is helpful for these patients, very much so. There's nothing against it. Again, because it's ketotic hypoglycemia, so they do well with high protein. There's no problem there. And it improves their growth. I had 2 patients with Fanconi Bickel that were basically not even moving. They couldn't walk. They were, let me put it that way. They had severe rickets with all the manifestations, and now they both walk on their feet and they do very, very well. So high protein, limit, in this case, galactose. So you can't give them milk, but you can give them fructose. So it's okay to get fructose, but not galactose. These patients, when you give them a glucose infusion, is fine. So glucose, even though it's a glucose galactose abnormality, you still can give them glucose, but don't give them galactose. They can get almond milk, they can get other varieties and so forth, but just don't give them galactose. Fructose is not a problem with their absorption. The other thing to make sure that you want to do is the cornstarch. If you are giving it, they don't need very high doses. If you give them high doses, it's a glucose utilization defect. So they end up having postprandial hyperglycemia again. which can cause the insulin to peak and bring them down. So the doses of cornstarch need to be, on the lower end, less than 50% of the carbs and so forth. They can eat carbs, complex carbs in food, but limit the doses of the cornstarch not to be high. Hope that helps.
Thank you. And then the last question is from Caitlin Weishoppel, asking, can you have both type A and B GSD9, so PHK-A1 and A2 variants? Have you ever seen that, or is it possible?
Yeah. So do you have pathogenic mutations? Each one a pathogenic mutation, or is it VUS in one and one in the other? So, synergistic heterozygosity, that concept has risen before in patients with fatty acid oxidation disorder, and Dr. Jerry Buckley has a paper about that. So if you have two mutations within a pathway, can they be involved and lead to a problem? So just to let you know, we do look for muscle disease in GSD9 because some patients have had CPK elevations. So it doesn't harm to look for a CPK. As for can two different mutations occur and cause a problem, I think it's possible if they're within the same pathway and they have an impact. The point is, are you seeing clinical manifestations associated with those two mutations? And are you not missing a mutation in one of them that could have not been picked up because there was, for example, another mutation somewhere else? So you want to first limit, that you've done all your best to find out if there was a second mutation in either. And if there are clinical consequences, what are they looking like? Is it liver, or is it muscle, or is it both? But we have seen both in some of the GSD9s in general.
Very good. Thank you very much, Dr. Gharbawy, and thanks everybody. It's 1:31, so we will sign off for today. Again, stay tuned next week for Dr. Amu, who's going to be talking about urea cycle defects in the third amino acid lecture. So thank you very much, Arig. Really appreciate your
Sure.
time and great presentation. Thank you.
Thank you all. Bye.